Investigations in community-acquired pneumonia. General investigations are aimed at confirming the diagnosis, assessment of the disease severity, and guiding appropriate treatment, assessing the presence of underlying disease, enabling identification of complications, and monitoring the progress of the disease. Oxygenation assessment. Those with an O2 saturation below 92% on the admission with the features of severe pneumonia should have ABG measured, and the inspired O2 concentration must be documented. Chest X-ray. Consolidation most commonly in the lower lobe, also interstitial infiltrates and cavitation, and multi-lobe involvement more common in bacteremic pneumococcal infection. Pleural effusion more common in bacteremic pneumococcal infection. And lymphadenopathy uncommon but most likely with mycoplasma infection. And the multi-lobe involvement, cavitation, and the spontaneous pneumothorax suggest Staph aureus infection. And upper lobe preponderance suggests Klebsiella. CT chest unlikely to add additional information and may be useful if the diagnosis is in doubt or the patient is severely ill and failing to respond to treatment in order to exclude abscess formation, empyema, underlying malignancy, or other interstitial disease process. Blood tests include complete blood count and counts above 20 or below 4 indicate severe infection. Renal and liver function tests can be indicated of severe infection if there is disturbance in the function or point to the presence of underlying disease, and liver function tests may be abnormal, particularly with right lower lobe pneumonia. And raised urea is a marker of more severe pneumonia. Metabolic acidosis is associated with severe illness, and CRP may be useful in management, with high levels being more sensitive marker of infection than the white blood cells or temperature, and serial measures may be useful in assessing response to treatment. Microbiological investigations. The microbiological cause of CAP is not found in 25 to 60% of patients and therefore often does not contribute to patient management. And microbiological investigations include blood culture. It's recommended for all patients with CAP, ideally before antibiotics are started. About 10% with CAP will have positive blood cultures. The early availability of blood culture results within 24 hours of admission improves outcome. This includes the hospitalized patients. Sputum culture and sensitivity useful for those patients who have failed to improve to empirical antibiotic treatment and in those with non-severe pneumonia admitted to the hospital who are expectorating purulent samples and have not received prior antibiotics. So blood culture and sputum culture not done for every patient, but can be done in those with severe pneumonia or those admitted to the hospital. Pleural fluid if there is pleural effusion for microbiology and sensitivity and pH to exclude empyema. Viral and atypical pathogen in severe CAP only, and serology tests can be done. Now we'll refer to specific tests for some pathogens such as pneumococcal pneumonia. Urinary antigen has sensitivity of 100% and specificity of 60 to 90% for invasive pneumococcal disease, and testing is recommended in all patients with severe community-acquired pneumonia. Legionnaire's disease, a number of immunological tests exist to aid in the prompt and accurate diagnosis of Legionella pneumophila, and urinary antigen detection is about 80% sensitive and more than 95% specific for serogroup A, and rapid results can be obtained early. A positive urinary antigen test correlates with subsequent ICU admission. Direct immunofluorescence, Legionella pneumophila, can be detected on bronchial aspirates, and the culture is 100% specific sputum endotracheal aspirate in bowel or pleural fluid, and serology antibody levels and PCR are also available. Mycoplasma pneumonia PCR is the method of choice for diagnosis, and the complement fixation test is the commonest serological assay, and culture of Mycoplasma pneumonia is not generally available. Chlamydophilia can be detected using PCR or antigen detection using direct immunofluorescence on respiratory samples or by complement fixation test, and others organisms such as influenza A and B and adenovirus and respiratory syncytial virus, PCR or serological testing, Coxella Burnetti indirect immunofluorescence antibody tests.